Great. Hello, hello, testing. Awesome. Well, welcome. Thank you for joining us. We're so happy to see you. I'm Kamaria, the Senior Research Assistant at the Cure Lab. And don't mind me, but I'm going to be reading. So if I look down, just ignore that. Anyway, so let me first share what we have in store. So first, I'm going to talk about kind of what this project is, what the SDOH in Place project is. You already know, I'm sure, that's why you're here, but just a little refresher. So the project, the SDOH in Place project, works to build a community of practice around defining and using community-level social determinants of health, and also demystifying design thinking that is crucial to developing web applications, right? And so we had a cohort of 15 lovely professionals that we used to help test out our community toolkit. The main goals of the project were to develop a new community toolkit that I just mentioned, to help people work with place-based social determinants of health data, develop apps, and we wanted to build a new search platform, this data discovery app. So we'll be talking about that more later. And we also wanted to build a community through discussing how do we define SDOH and how do we use that data. Then we wanted to engage new types of collaborators and applications with design justice. Lastly, we wanted to develop new types of infrastructures and tools to use this data. Which brings us to the present, and we are here today. Like I said, we had a cohort of 15 people, which we'll hear more about them tomorrow, but they are all here today. If you see their, I think their tags are orange, so keep those folks in mind. And we are also lucky to have some speakers here to present to you today. They're going to be talking about the unique research that they've been working on using SDOH data. And today we'll also do a lightning session, or Pachakusha. You have no idea how much I practiced that. You have no idea. I knew I was going to mess it up. Oh my gosh, okay. Pachakusha. If I do that again, just yell it, Anyway, okay, and then we have a reception today, later at, I think 5:30, something like that. But after dinner, 7 p.m. on your own. So that means find a restaurant that you want to go to, pick some people you want to be with, and eat together. So we also have a website where we have some list of restaurants that you can choose from. Maybe it's just some options. Our Symposium website, the name I think is on the front page of the program. If not, if you want to look up symposium2024.sdohplace.org, there you can find good information, some information about our speaker, the fellows, and other things we do in the city. Lastly, feel free to take some pictures and use our hashtag SDOHplace2024. That is hashtag SDOHplace2024. Take pictures, post them, shout us out. We would love to see how much fun you're having. Now, we are going to just do icebreaker. I know you love icebreakers, and so that's why we're doing it. Okay? You told me, so this is all because of you, Tyler. Thank you. So each person will write a word on a piece of paper. Wait, first, any questions? Sorry. Any questions? No, you're good, right? That was very clear. Okay, great. Okay, so choose a word. So think of a word, any word, random word, and then you have sticky notes on your tables. So everyone grab one sticky note, write a word, fold it, and hand it to the person on your right. Any random word, just one word, that's the rule. Hopefully. So pick a word, pass it to your right, or your left, I guess. Mostly your right, because then everyone can get your paper. Don't put your name on it. It has to be anonymous. And then after you pick your word, just talk amongst yourselves, but basically what you'll do is the new word that you have in your hand, you'll say, I think this person chose this word because, whatever the reason you think it is. And then when you're all done, then you'll share the real reason why you chose your word. So for example, let's say I wrote the word cow and I passed it to Mark, whoever Mark is. Okay. And if I wrote the word cow and he's like, oh, I think Maria wrote cow because she likes that animal. And then I would say, no, it's because I'm as hungry as a cow. Okay, yeah, so go ahead. You can start now.
Similarly, I think Anika actually, when she's done it, she wants to be perfect. I think it's just like teachers. Oh, okay. You want local, yeah. It was in a lot of my passwords. Phased out, so it should be safe.
Thank you.
It's getting quiet, so we'll have a few more minutes to talk, and then I want someone to share something a word, I guess, or discovery that was funny. So I want to laugh too. I had a lot of laughter.
More like a style. I'm not aware of that.
Yeah, I like that.
It's like I mean, it's cheese and sauce. I'm still on board. Yeah.
Okay, so do we all get to share? Yeah? Okay, so can someone tell me what was funny? Because I want to laugh. Yes. What was that? Yeah, go ahead.
Guinea pig.
Guinea pig? Okay.
Yeah.
And so why did you choose guinea pig? Yeah.
No, I just do it.
Okay. Why did you choose guinea pig?
I like my guinea pigs.
Okay, nice.
We had a nice conversation with her first pet with the guinea pig.
Oh wow, how sweet. Really? I feel like guinea pig is a great pet. Yeah, it seems like it. I would love a guinea pig. Awesome, thank you, thank you. Anyone else want to share? Yes, let's come over here.
The word random.
Random.
Very interesting.
So, Jonathan?
Yes.
Wow, my husband over there, he chose the word random. Nice. I guess I know why you chose it, because I said random, so great.
You guys are lying.
Awesome. So we have another couple minutes, so can we get another word? Anyone else? Share a word that they, yes. Yes, Sarah.
I picked Kachakucha.
Kachakucha. Wait, is that how you say it? Pashakasha. Pashakasha. Wait, is it Kachakucha? Pashakasha. Exactly. Okay, no. See, it's a hard word. So you chose it because we.
It's literally all I can think about.
Oh, yes. All you can think about, yes. It's a very creative word. Awesome. Well, thank you so much for sharing, for sticking with me for these past 10 minutes or so. We have a couple minutes intermission, I guess, as we wait for our next speaker, which is Babu. And I think we're gonna just set up and I will introduce the first speaker, I said next speaker, first speaker of the day. So just give us a couple minutes and then you'll hear from me again. Thank you.
This is yours, and I just need to make sure I stream it.
Very human. Yeah,
Slideshow. Wait, did I read? Okay, slideshow. And I will introduce you real quick, and then do you want to use the mic or? I will.
Alrighty. Hi. Welcome. Okay, so now moving on to our first speaker, Babu. We will be discussing social service implications by presenting results as practical engaged GIS tools with community maps for one, distributing healthy food locations to strengthen resident health promotion and food assistance programs, and two, contextualizing social economic inequities to support advocacy for food justice. And so here's Babu. If you have any questions, just hold them till he's done. Thank you.
Thank you for introducing my presentation. Hi everyone, it's great to be here today. My name is Babu. I'm a PhD student in social work at the University of Illinois Urbana-Champaign. I really appreciate the organizers bringing us together here about community health. So my topic today is space, place, and food justice, and how we can use engaged TIS tools for community service opportunities. On the next slide, I have just a brief introduction. I think we're all familiar that there's a lot of increasing health epidemics going on. and this disproportionately occurs at higher rates in marginalized communities from obesity, diabetes, and more recently we saw with the impacts of the COVID-19 pandemic. I think we're all pretty familiar that health behaviors and outcomes are beyond individual differences and genetic makeups, and it has to do a lot with our built environment and where we grow up in, or the zip codes we live in, and so on. Interestingly, we've had a lot of research talking about food access when it comes to supermarkets, common food stores, and it consistently finds that there's less availability, longer distances to get there in communities of color, other marginalized communities, and low-income areas. And for the supermarkets that they do have, there's actually a higher proportion of unhealthy foods to healthy foods available there. So they face kind of a double burden there in trying to access healthy food. This day and age, we see a lot of new urban agriculture type foods from farmer markets to urban farms, and this could potentially provide some avenues to help close the gap given its healthy, nutritious foods that are available there. And for me and my field from social work, we don't typically engage with GIS or spatial visualizations, and I think given the importance of food justice, environmental justice to social workers and social service fields, this is a great opportunity to use that for community service work. On the next slide, I want to introduce my research objectives for this specific project. So basically, I'm looking at how is access to healthier grocery options associated with both space and place. And by space, I'm talking about the spatial distribution of urban agriculture across neighborhoods, and place has to do with those social determinant of health factors that are associated with differential access. And I'm highlighting their access because I want to acknowledge that access means something different to everyone, as it should be. And there's a lot of dimensions and factors about it. And in this project, I'll operationalize it in a specific way, which I'll mention in a coming up slide, but I just want to acknowledge that aspect of access. And the overall goal and objective is really how could we tailor these findings to really create opportunities for more food equity and food justice for marginalized communities. In the next slide, I have some more information about kind of the approach I'm taking. I do draw upon some theoretical background and interdisciplinary frameworks. In general, I'm drawing upon critical theory, which is looking at challenging the status quo, the barriers that exist towards inequities, the structural and systemic factors that are contributing to what we're seeing socially in our society. Specifically, in the field of environmental sciences, there's a scholar, David Powell, that put together critical environmental justice, kind of conceptualizing some aspects of it. A couple of points he considers is one that he is acknowledging that there's this spatial dimension to injustices, that they do occur across space, and it will affect what happens in one area affects another area, and unfortunately marginalized communities have been disproportionately adversely affected from these harms and injustices. Moreover, there's an importance to consider multiple social identities. These are intersectional issues. They're not just affecting people on a single social scale, whether it's race or income. And it's important to look at different identities and different ways communities are impacted uniquely by it. Another framework I want to call attention to is a quant-crit framework, which is an analytical framework from the education field. And this is about more of kind of interpreting data, and even with quantitative data and measures, it's making the view that these are also socially constructed, and with them it might be measuring points about structural issues, other barriers, and if we need to look at how has it been used in the past, whether it might have been disadvantaged ways such as labeling or looking at things in terms of deficiencies, and moving and shifting toward more of a social justice framework, using that towards equity goals. So I'll bring that up in how I kind of translate some of our findings today. So for the methods for this project, the setting is here in Chicago, where we are this weekend. It has a rich history, of course, with a lot of social conditions and factors, and a lot of segregation and other historical context, redlining and so forth. So it makes an interesting place to study. It's also benefited with a lot of rich open source data that's available, and I'm drawing here upon two data sets. One is the Chicago data portal. They have geospatial location information of different urban agriculture stores, as well as community service centers and community boundary areas to help spatially visualize this information. I'm also drawing upon the Social Determinants of Health Atlas, which is made available through the Center for Spatial Data Science. And in that is a lot of important and useful social determinant of health information. So I'm first, going to analyze space, and I want to also be able to create a community resource map that can be used for engagement in communities. And that's going to include these different locations of urban agriculture. And I'm going to also create and implement a spatial variable for access zones. And here I'm going to operationalize access in terms of availability and proximity based on these buffer zones. In addition, I'm taking a more conservative approach than previous literature and how we're kind of defining these access zones by kind of trying to incorporate other travel behaviors that affect access. So not just specific distance from residents, but who are the people that are going to access that? What are their differential transportation options, their own physical abilities, and other social factors that can impact how willing they're able to go or how far they're able to go. So we'll see that in the map. And then when analyzing place, we're going to draw upon that social determinant of health data. And that's published data by Dr. Polik and colleagues recently in 2020 that has typologies of different communities at the national level. And, what is the different dimensions? They kind of narrowed it down to 4 different dimensions that underlie these typologies from 15 different factors. So I look at that specifically for Chicago, and we'll see how that might compare relative to our map of healthy foods. So on the next slide, I have the first map here, which is a community resource map. And here we can see in orange is our farmers markets, in blue is our produce parks, and green is our urban farms. And we have a quarter-mile access zone around produce parks, as it's been said in literature that people are really, most part, not willing to travel more than a quarter of a mile for the greatest amount of population. Farmers markets, we know, are less frequent, a little more popular. People might be willing to try to find ways to get there, a little farther distance, a half a mile. And then for urban farms, we know there are less of those, and they have greater supply of foods available, and they might be servicing more people. So we use a little larger zone, 3/4 of a mile, but still at the conservative end, less than a mile, where more literature typically uses more than a mile. And this approach kind of ensures we're not finding kind of food mirages, which are places that look like has food available, but is actually inaccessible and not accessed by the community. And here we can see that in the northern communities of Chicago, we have quite a large concentration of urban agriculture, especially produce parks and farmers markets. But as we move into the south, we see greater gaps, or these deserts we will call. However, uniquely, we do see some more urban farms located there in the south, and that could potentially offer some implications for community services, which I'll talk more about later. On the next slide, we're going to start looking at some social determinant of health information. And here we're going to compare the typologies for the Chicago communities using the Atlas, 7 different typologies there. And we see in the south, in the dark blue, is all communities that have been identified as extreme poverty areas, while we see in the northern parts as orange, which is urban core opportunity, those kind of dense cities with a lot of economic opportunity, rent, public transportation available. So we see that stark contrast, which has a nice comparison there, almost similar patterns to what we see in the distribution of urban agriculture. On the next slide, I want to show a table here of the dimensions that underlie the typologies. In the work by Dr. Kolek that I mentioned earlier, they came up with 4 dimensions from their analysis. 1 is socioeconomic advantage, 2 is mobility and isolation, 3 is urban core, and then 4 is mixed immigrant. And when we compare these by typology group, we can see that there's a stark disparity for the first three factors between the extreme poverty areas and the urban core areas. And specifically for the first two, we see negative scores that represent disadvantages. So these are areas that are being characterized by having limited mobility, isolation challenges, as well as socioeconomic disadvantages. In the next slide, I look at the specific factors that are going to, this slide before that, yeah. So these are the specific factors of those first two indices that I mentioned. So probably as expected from previous work, we do see that in the extreme poverty areas, we have more than double the amount of people living in poverty, double the amount of people that are identified as a racial minority group. We also see that their education is lower, so they have, as we expect, socioeconomic disadvantages, unfortunately, from being located in the southern communities of Chicago. When we look at some of the mobility dimensions there, we see older age is not much of a difference between those two areas, but we see a disparity there in the amount of the population with individuals with disability and those unemployed, almost double the rate. And in this indice, we included those top factors. We also included unemployment here because that's not one of the ones that are called out specifically in the original paper of the published literature, but it is a top three negative factor, and we wanted to consider that because it's part of the social isolation when you're not going out because you're unemployed and you don't have those opportunities to interact in the community and access places that people with a social network and employment have. So in the next slide, I want to kind of just sum up and say, what does this all mean? Where can we go from here? So these are really, I think, as a social worker, I see these results, this engaged GIS and community resource maps of social determinant of health information are really excellent opportunities that can enhance the work that we're doing as social workers and community service individuals, volunteers, and so on in 2 to 3 different ways. I think first we can utilize these resource maps. This is probably information that a lot of people are not seeking out themselves. They have a lot going on their plates. They're not going to seek out these urban agriculture if it's not, right in front of their door or down the street. So we can at least inform them with these maps that these exist. And then 2, we can, as community organizations, we can use this to help prioritize our outreach efforts and our resources. We know these groups that are doing work in the community that have limited resources, they have limited funds, they have to be able to prioritize where they can outreach and who they can help. And it can be an opportunity to now identify, look, that urban farms seem to be exist in the South. Is this something that we can create more connection towards with those urban farms workers, with those owners? Can we involve the community more? Can we provide more of their food to different community members that need it? And community service workers, social service workers have those relationship skills to build that and to strengthen that partnership. Next is this really presents an opportunity to create participatory programs that's really community driven from the needs and voices of the community. Unfortunately, there's a lot of areas that are in need of more equity and services, but they don't have the data available like Chicago does, or the resources that some of the places in Chicago do. But this is where we can use methods like participatory GIS, where we can engage members in the community to help us collect data of the places they're living at, the places they're going, their activity spaces, and maybe even incorporate it with some funding or employment programs where we're actually paying these individuals and supporting their income and supporting their livelihood through these participatory programs. We can also organize social networking events at community centers. Maybe we can have a pop-up food center for food we can get from farmers markets in the north down in the south. Have people create that social network, those social ties that are important when it comes to facing barriers. We all know that experience when we're in COVID-19. You're in such a better position when you have a social network to rely on. These are people that need that network every day. And finally, this is really also a tool that can support advocacy work for justice, which many social workers do in other fields around health and social well-being. One, it can help their requests for funding, right, through grant applications, to other type of funding sources, to use this as evidence of this is a big equity issue. The visuals, the information can help hammer that point home. And it can also be evidence when we're advocating for specific measures. Maybe we can get more accessible transportation services for individuals in the community or in part-time job employment opportunities and so on. And going back more to that quant print approach that informs a lot of these, is also we need to use this to help draw more attention and bring more awareness to the structural factors of the inequities that are contributing to this, such as the racism, the classism, the capitalism, the ableism, and so on, that are contributing to a lot of social injustices. So I'll stop there for today, but welcome to take any questions and comments. Oh, yes.
Great presentation. I was going to ask you which of those community partners that were wanting to actually do that work that you're talking about. Like, was it young people? Was it people in environmental, or is it people that worried about whatever? And where were them? Where were they? Like, were they in Chicago? Oh, because this was from Chicago only.
So that's a good question. Thank you for the question. So what I present today is data about Chicago. And this was done without any direct work with communities. But a couple communities we are doing work with. One is in Rantoul, which is in Champaign County, located by a former military base that faced a lot of environmental inequities, including access to healthy foods. And they have a young population that they want to bring up better educated, more opportunities. And they have a lot of unemployment and low income. So we're working with them to see what funding opportunities we can draw upon, where we can utilize programs like these, engage the youth, engage some people that need work to help, put together some of these participatory programs, maybe even community gardens where they can also benefit with growing some of their own food. So there's a lot of communities that I feel are, from the feedback, from the conversation we have, are really interested in this because it engages youth, it engages people that need opportunities for employment, need opportunities for health, and they just need the people to help them get there. So I think that's one of the communities we're working with, and we hope we can get more in Illinois. Yeah.
And you said there's another one too?
So two other ones that we are working with. One is Danville. We work with them on some broader issues, and they brought up concerns about food deserts and inequities, and we're in early stages on potential, work there. And we also work with youth in Muhammad, which is has an interesting demographics and socioeconomic characteristics. But there's a mobile park community there that faces a lot of water contamination issues. A lot of them don't have access, have faced food insecurity. That's a little more challenging situation, but we're seeing how we can draw upon these resources and tools to help. Thank you.
Thank you so much. We're about out of time. We really appreciate that. We'll give it up for Barbara one more time. And so to Jose.
Yeah, thank you. Yeah. Do we have the presentation?
Yes, I'm gonna get it right now. But I just have to first. This is it right here. Right, yes. But I have to make sure. Where's it? Share screen. Share screen. And it is PowerPoint presentation. This one. There you go.
Ready, go for it. Okay, thank you, Babu. I have also questions, but to continue. So moving on, I'm really happy to present one of my dearest friends here in Chicago, Dr. Juanita Reina, who has been a senior epidemiologist for the Chicago Department of Public Health for the last 25 years. Dr. Reina is also a community organizer. In 2021, she created the Data Leadership Academy to empower communities and provide them with hands-on training with real economical data in topics such as community engagement strategies, data-driven storytelling, policy development, and effective communication strategies. And I'm really happy to hear with Dr. Reina. to talk about this amazing and wonderful project. So please help me to welcome her.
Gracias, Jose. Encantada. Okay, this is probably not gonna work, but it's fine. Okay, I just don't want to spill that. Okay, thank you so much. It is I'm so happy to be here. And thank you, Babu. Where's the word? That was an amazing presentation, and I always have to ask a question, so he will follow up later with the other question. But because it's also amazing, and I'll tell you that in a second. I am a graduate from the University of Illinois Urbana-Champaign. Not only that, but I am also a graduate of the UIC School of Public Health, and also almost finished my PhD, but I'm not that yet, but maybe that's what.
Soon enough.
Soon enough, yes, for my PhD in epidemiology. So, this topic is called the Data Leadership Academy, Powerful Data-Driven Community-Centered Storytelling, which is there's gonna be no maths here. Because you did all the maths, good job. I do maths, of course, but not in this presentation. It's about process, how we do things differently. And can someone, could you give me like a 5 minute and then like a 1 minute?
Yeah.
Because sometimes I tend to, go a little storytelling and get carried away. So, but I'm gonna go over here. Okay. So, do you want to change my slides? Of course I do. Yes, I don't have them. Okay. So this is me. Picture was from like 2021. That my friend did because I was too cheap to get a headshot thing. It's for free. A community organizer, a first-generation daughter of Colombian parents who immigrated slightly differently. My dad went through New York when my grandfather passed away, when my dad was 19, studying at the Universidad La Nacional in Colombia, Bogotá, civil engineering. My mom came in 68, well, my dad came, I think, like 66 or something, to New York because his mother, my grandma, we called her grandma, that's kind of weird. It is very weird, I'm sorry, because I grew up in Arlington Heights, but I was born in Uptown, but like grandma, we called her grandma. Anyway, so she came to live in New York City, which if people know me, like I love New York City. When I'm in New York City, people think I'm from New York, of course, like Queens, because that's where she lived. In the Colombian neighborhood, which is, I think it's called Jamaica Heights or something, maybe, I don't know. Anyway, I'm Latina, I'm a social epidemiologist, and there was not a social epidemiologist until 2014 at the health department. Only like maybe in New York City or over there on the other part of the United States, like Berkeley or something like that. But in 2014, my title is a kind of social epidemiologist, which is like place and all this stuff. I'm a visionary, strategic partner, community member, activist for social justice, data-driven, relationship builder, innovator, mentor, mother, wife, and storyteller. Okay. I'm not going to spend too much time on this next one because I think you guys all did the slides, right? Oh, that's me. I think I have like, Sophia, can you come help me? Oh, yeah. Yeah. So, thank you. Uh-oh. Uh-oh.
There you go.
Okay, I'm not going to spend a lot of time on this one, but my previous supervisor, when I got ready to give this talk at the Department of Health Board of Health meetings, and if you ever gone to those meetings, I don't know, like I went over my presentation and she's like, no, you need to do this in chronological order. So there you go. So over here, I'm going to be very quickly, like you can ask me anything at any time, but this is be fast. People often ask me when I did do the work that I did. So if you remember the COVID, I was on the TV and the Protect Chicago talking about the COVID vulnerability index to do the prioritization of the vaccines and figure out who's getting infected and who's dying and all that other stuff. So people often ask me like, gosh, why are you so good at talking to people? If you ask my kid right there, because I like to talk. I like to talk a lot. So these are why I'm kind of good at talking to people. Well, I'm a gun violence survivor. So 31 years ago, when I graduated from UVI, then I went to do my PhD in, wow. So you can look me up and then you'll, but you can ask me. But in 1993, I went to Bogota to do my PhD in political history, of Colombian political history. And I already had my dissertation ready. It was going to be to reintegrate the Guerrilla movement into society. Simple. Yeah, like peace in the Middle East, like simple, right? So I was like, I want to learn about it, so figure out how we can make peace for real. But then I got shot 5 times when I was there in spring break. So, and that was really bad, and I didn't get to the hospital the next day, and I was in a coma, and I wasn't able to speak, read, or write, like when I woke up from the coma. And it took me a while to be able to talk again, which is kind of remarkable that I'm just talking right now. And I also sing and play the guitar and things like that. But anyway, so this is basically the surviving, and I volunteer a lot. It's a little over excessive. Volunteer in public health, which is where I got my job in public health. When I got back from Colombia on May 31st, the TV people were there because I was kind of like famous a little bit or whatever, And because I also was part of this small movement in University of Illinois, Urbana-Champaign, where some of the Latino students shut down the administration building on Cinco de Mayo in 1992. And they asked me to be the spokesperson because he told me, I was like, why me? Like, because you don't swear and you're really good at talking. I'm like, okay. So when this thing happened to me in Colombia, about a year later, like 11 months later, the ABC News was like all over it because they showed all my stuff and they're like, oh, it's like a whole like, I'm like, it didn't really happen like that, but whatever, So I got back and then I needed to find my purpose because I was really happy there. And I started volunteering when I was on public aid, and I found myself now, like 31 years later, everything that I do is for a purpose, and even being here is for a purpose, and my whole family is over there. But I was on public aid, and the public nurse that came to our house to change my dressing, which I have a bullet over here, and the other ones are like out. Of course I knew about public health because a couple years before I worked for the Champaign County Healthcare Consumers. Does anyone know about those people? No, really? So Champaign County Healthcare Consumers are like a very, very grassroots organization working to end sort of like discrimination against people like on Medicaid and fight for universal healthcare. This was like in 1991. This was before the Clintons did all that stuff, right? People thought it was like a little cuckoo. So I was going door to door because I had a job lined up for that summer because I was doing some independent study with this really awesome professor. Predating my PhD like the year before. And I got this great job at the Park District teaching swimming lessons to disabled kids. And I was like, oh, this is awesome because I'm like a swim coach and stuff from before. But then right before the summer started, they're like, oh, I'm sorry, we don't have money for the grant that we told you. And I'm like, oh, goodness gracious, because I had already got the apartment, and then there's no job. And so, I had to go knocking door to door to be working for the Champaign County Health Consumers. So anyway, it's all the stuff that I do that sets the stage for this Data Leadership Academy. So, just one more thing. So at the very end, all the stuff that I do in the health department, so working from like the maternal child health epidemiologist, I was at 1999. I got my job after I did my MPH at UIC in Epi. I also, before I worked for the city, I did this like community engaged research in the Lathrop homes, and they don't exist anymore because they like kind of sold them to whoever. But if you're not familiar with that, it's like kind of by Logan Square on Damon and Diversity where the Costco sits if you're from Chicago. So there used to be this Lathrop homes where it was very, very dangerous. And the pediatric chief resident wanted to find out what the community needs. Because before he wanted to give a community health clinic, he wanted to make sure it's what the community needs. So he wanted, he got a small grant from American Academy of Pediatrics, and he hired me to find that out. So I created this a health committee within the structure of like this network of the Lathrop homes. And I asked the community, we created this thing together and the survey, and we were able to get these parents who were parents of CPS, like across the street. And I can't remember the name of the school, but it's right there, across the street from the, like, by Wellington and over there by David. If you, no, somebody knows it, just shout the name because I can't remember. Anyway, we talked with the admin, the social worker, all these people, with teachers, got right in with the parents. And because the person in charge had these residents, because he was in charge of the pediatric residency, he said, oh, we have these free, like, training, like, doctors, we can provide 5 minutes, great. So, wonderful, I could talk. So basically, that was actually so meaningful because we gave the kids for free the what's it called, that they have to do before they, the physicals and all this stuff, right? For free. So then I had the parents do the survey. And so basically, the end of the story is, which is super meaningful, because this was like in early 1999, is that they need mental health, like 70-30, right? So the whole purpose is, as an epidemiologist, I need to know what the people need. So we can go advanced. You can see this later. Oh, you know what happened at COVID, blah, 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 blah. Oh, there is maps that I made. Look at this. So this is big news. Well, it's not really big news, but a lot of people died, like, right? Latinos and African Americans. African Americans, actually, the numbers died more, slightly more. However, our Latino people, we died younger. A lot younger. So these red community areas are community areas where the life expectancy from 1 year to the next changed dramatically. That says 5.2, I think, or negative, like going down to 3.5. That is remarkable. All of these in that list, besides one, I think, Grand Boulevard, I believe, are all, oh no, Ashburn too. Most of these community areas, most of them are Latino community areas. Okay, next slide.
Great.
That's okay.
Yep.
Okay, so then really quickly, I have like 2 minutes, 3 minutes.
How many, Mark? 2?
3.
3 minutes, 3 minutes.
I'll go back. So the chief deputy for COVID Bureau, since I was like good about talking to people, about data, blah, 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 I was doing a lot of community engagement to do in the Belmont Cragen, most specifically Northwest Side, the West Side, which was very difficult because folks on the West Side were like not interested because, the trust issue was not there. And they're like, no, thank you. You can give them air fries. They don't want that. They don't want nothing. No vaccine, mostly. So they asked the person in leadership asked me to create a data capacity for all of the HCEZs, which were funded agencies that we fund through the health department, so that they can create their own sort of realities and use data. So they didn't hire me because I did it for free, whatever. But they brought me in the room. I'm like, can you do this? I'm like, yeah. Is that a promotion? Like, no. Is that a more money? No. I'm like, oh, I'll do it. So I did it, and it was really fun. So we had 21 fellows, and basically we taught them, Babu, exactly what you just did. So I'm not going to go into this other stuff, but I'll show you real quick. The whole, we had 4 main objectives: access to hyperlocal data. Everyone has access. Everyone gets a car over. Everyone. Yeah. Thank you. 1 minute. So we had use of data to prioritize resources. That's what you said. Effectively communicate findings. What you said. And then learn how to write research questions. Epidemiologists at the health department really don't know how to do research questions. Come on. I put that in there because it's like your problem. So I wanted them to know that that's a research question. And it's almost done. And these are the actual sessions. Or unfortunately, we had to do it on Zoom because the whole, was it Omicron or something was terrible over there, like in the beginning of 2022. This is our objectives for each of the classes. The final presentation in person, remarkable. 10-minute presentations that fellows did themselves. I didn't do it. Each region created their priority: mental health, diabetes, whatever, housing. And so they had to create presentation. I made it so they couldn't wait till the last minute, right? Because I kind of had the ADHD, so I wait till the last minute. I said, no. They had to turn in their research question on this day. They had to turn in their PowerPoint slides on this day. I mean, some of them didn't turn it in on time, but it's okay, right? Anyway, it was great. It was fabulous, blah, blah, blah. That's all this stuff. You know, these are people learning about their community to change their community. And I think this is almost done. Oh, these are pictures, and then this is stuff. Oh, that's you, everybody. Like, this is you, people. That's a puzzle. We need people, not just us, but people that don't know what epidemiology means, don't know how to make a map, because we're not asking them to make a map. We're asking them to look at the maps already made by Babu or somebody else, and then do something with that. So I think we're almost done. Oh, that's what I use at the beginning, and that's one of the presenters. Oh, I did it by way of using people in their communities that know their communities the best, and they were the presenters. We also had the chief of staff, my friend Cristina Pasternas, talk about participatory budgeting when she was a senator. My friend Rosanna Rodriguez, who is alderman on the Northwest Side in Albany Park, talk about how you bring youth in and knowing, you know, how to change your community. Many, many others. I've done this, keep going, I'm almost done.
Okay.
The atlas, or the census and the atlas, and these are, oh, hold on, one more thing before. That's the one before it, this one. So Metopio is a folks that do the Chicago Health Atlas. When it's in 2022, I was asked to be like the bottom part of this like webinar, and the lady who organized it said, "Oh no, Margarita, I need to do a whole nother webinar, and you're gonna be like the spokesperson, like you know Oprah or something. I don't know." But these are 4 people that talked about their experiences, and I, as a moderator on this webinar, I mean, I'm sure I can send it to you.
Yeah.
It's just, you know, available. And they talked about their experiences and what they learned. It was like so awesome. And one of these people is my really, really good friend, Cindy, who her and I created the longest standing community clinic for vaccine in Belmont Cragen at the Bricktown Mall. And she is amazing. And she's now the chief of staff right after she graduated. Oh, well, she is the chief of staff of ASI Home Care in Chicago on the Northwest Side. She's amazing. And they're all amazing too. And then I think we're done.
Yeah, we're all the same.
Yeah?
Yeah.
Done. Okay, how's that? Yeah? Question?
Oh, yeah.
No questions? I love questions. Sophia?
Sonia.
Hi, yes.
I'm obviously gonna look this project up. It seems really awesome. I was wondering if there's any resources or guides for community leaders or community members or anything like that.
Well, I have given some talks like this so many times. And yes, but it may be in my own consulting firm. So we'll talk. Because I found that I like to do volunteer things and I do them too often. And I went to the World Happiness Summit in London in March. And then I went to Australia for the positive psychology diploma course. And I'm a positive psychology coach on the side, and I haven't charged anything to anyone. So lots of people email me, I do Zoom calls and this, and I'm like, but I think I'm gonna do it like separately. But yes, I'll be happy to help you or anybody else. And no, Jose has my information.
Yeah.
But yes, of course, it's very easy. And I was gonna start with this, Babu, because that's why I asked you. All those, you know, I'd be happy to help you with those things if needed. Any other questions? Oh, I didn't drink my tea. Surprise, surprise.
Final round of applause for Alrighty, so while we set up for the next round of speakers, we're gonna take a quick 10-minute break. We'll be back at 3:50, so feel free to get yourself some more coffee, more snacks, use the restroom. Restrooms are by the elevator, just by the by. Yep, we will be back at 3:15.
Not this area, but, no, I mean, actually, I'm not, I didn't grow up, but I've been here for years. Still lots of people.
So I sent you an email like
We're away from the.
Yeah. But like, you know, change.
Oh, yeah.
Just like.
As soon as it starts, I'll set.
I mean, I think it's just been like.
It's true, though, and you're internalizing it.
All right.
There's some Star Wars.
I don't want
I'm amazed at your ability to continue to brand it. She brand us. Because how did that work? Just to the right P2. Hold on a second. But yeah, everything else. I'm trying to follow Peter around. Peter's
I'm so sorry.
well, in other words, it's a lot of food options. Oh, very good. You cannot hold that in. Do not ask us to hold that in. If my wife were to, she would probably do that. I like it. That'd be really fun for us. Every friend just keep the table weight. Yes. Oh, yeah. That is my friend. Oh, I'm sorry.
Attention. Attention, hey everybody. One, two, three, all eyes on me. Does that work? Does that work for everyone? Okay, one, two, three, all eyes on me. Does that work? It does work. There we go. Okay, so welcome back, everyone. For our next speaker, we have Jacob Kizamba. Alrighty. We'll be presenting machine learning approach to developing a predictive model for local vulnerability to hepatitis C and HIV related to unsafe injection drug use. So let me just pull up my slides. Do that, or you can do either or. And I'll be giving you time. Sure. For me, 5, 10 minutes.
Hi, everybody. It's a great opportunity to be here, and I want to appreciate the organizers of this symposium. Thank you for having me come. Yeah, it's great to be in Chicago. So, I'm Jacob Gisamba, and I'm a PhD student in the Population and Public Health program at the University of Southern California in the Department of Spatial Sciences. But because of the interdisciplinary nature of my program, I'm also affiliated with the Department of Population and Public Health, as well as the Department of Sociology. Okay, so my background is pretty much in public health and much into epidemiology. And my previous work involved looking at the epidemiology of infectious diseases that cross from animals to humans. But during my master's program, I also did some work on epidemiology of HIV in South Africa, as well as non-communicable diseases among people living with HIV. So when I studied up my PhD, I was interested in the intersection of place and health, and trying to understand how different place-related factors could be related to influence the health of the population. So today what I'm going to be talking about is briefly what I'm proposing to do for my PhD work. And the overarching goal is just to explore and examine the spatial risk environment of blood-borne infections, particularly focusing on hepatitis C and HIV. And today what I'm going to be focusing on is just a sub-part of that work, which involves identifying high-risk areas to the syndemic of HCV and HIV in Los Angeles County, trying to combine the spatial thinking and machine learning approaches. Okay, so this will be the outline. I'll spend pretty much time just trying to describe the background, how high-risk areas have been recently identified in extant literature, as well as some methodological gaps, which I intend to address in my work. Then I will wrap it up in a few minutes with what I propose to answer the questions, the conceptual framework that will be guiding my work, as well as the analytical workflow that I intend to follow. And then most importantly is the public health significance of such work. Okay, so hepatitis C, for some of us may be wondering what it is. It's a viral infection which affects the liver, and it manifests as an acute disease, but if left untreated, it progresses to a chronic state, and if still left untreated, it results into liver cirrhosis, that's the scarring of the liver, as well as liver cancer, hepatocellular carcinoma, and it also increases the risk of death. So how is it spread? So it's spread through contact with infected blood, and particularly here in the US, it's through sharing of injection equipment, but also other modes of transmission can happen, like from prenatal transmission from mother to child, if the mom is infected with HIV. Also healthcare related interventions like blood transfusion. That's very rare here in the US, but it's very common in low middle income settings where blood is not tested very well. So the interesting thing is there is a treatment which is highly effective. It has 98% cure. And this has opened up room for the possibility to eliminate this kind of infection. So in the US, if we try to contextualize the problem, something should be showing at the top. I don't know why it's not popping up my heading. But what I have there is just contextualizing the problem in the US. So as you can see that the prevalence varies in all the different states. This is work done by CDC. I think it was published in 2019. But what I want to highlight here is that HIV is the most prevalent blood-borne infection in the US, with approximately 2.4 million people living with chronic HIV. And something very important to me is it disproportionately impacts people who are uninsured, experiencing poverty, unstably housed, and people who inject drugs. So since 2010, there has been an increase in the number of cases, as you can see on the graph on the top. And this is mostly driven by the young age cohort group. As you can see, 20 to 30 years, 39. And if you look at the bottom, there is a bimodal kind of transmission, bimodal kind of distribution, whereby we're seeing more cases among the young adults, as well as more cases among the older folks. And for the young adults, it's representing the opioid epidemic, which has been happening, because it is transmitted through injection drugs. So that's why important to take note of. Okay, so HIV manifests as a syndemic. So a syndemic is a co-occurrence of two or more infectious diseases or health conditions within the context of large social forces. So HIV co-occurs with HIV, as well as the opioid misuse and the overdose epidemic. And this syndemic unfolds within a multifaceted risk environment. And here what I mean are the different socioeconomic factors, the physical environment, accessibility to healthcare, as well as the law and policy factors. And this exposes or makes particular areas more vulnerable to this kind of infection, as well as it impacts engagement in care and prevention programs. So that's why I urge you that adopting a place-based approach in trying to understand this risk environment is quite very relevant. Okay, so why explore the risk environment, particularly here in the US? So globally and actually nationally, there are elimination targets for HCV, which is we want to get 90% of people diagnosed who are living with HCV. And within this population, still we need to have 80% of them treated. However, there are still a lot of gaps in here because CDC just released this study, I think 3 weeks ago, trying to show that almost all states are still below the elimination targets regarding treatment. And these gaps are related to high levels of unawareness within the population. The detection rates are still very low, as well as the linkage to care because of different barriers. So what I'm stating here is that these gaps are modeled by individual factors, as well as the contextual risk environmental factors. Therefore, understanding the risk environment could guide geographically targeted micro-elimination interventions. Where can we target texting? Where can we target linkage to care? Where can we target prevention methods such as harm reduction programs? Okay, so how has area level risk environmental blood-borne infections been assessed in extant literature? So CDC released a study in 2016, trying to understand the vulnerability of different counties to rapid spread of HCV and HIV associated with injection drug use. So basically, in this study, what they used was the acute cases reported to CDC as a proxy for the injection drug use patterns. And with different area level factors aggregated at the county level, we were able to identify which counties are more vulnerable. And as you can see, most of them on the East Coast, particularly the West Virginia, Kentucky, and Tennessee states, but also Other counties had some counties that, as other states had some counties which were also vulnerable. But something interesting about this study is it was used a lot to guide state level public health interventions, also county level, and also different local departments adopted the same methods to try to understand which counties are more vulnerable. For example, in California, I saw that acronym CDPH, which means Chicago Department of Public Health. So California also uses the same. So it's California Department of Public Health. So in 2018, they also tried to identify which counties are more vulnerable to the rapid spread of HCV and HIV. Thank you very much. Hopefully I'll be able to go through my other slides. They use the same approach that I showed in the previous CDC study, but they also identified that 2/3 of the counties were more vulnerable to spread of HCV. So there's some methodological limitations that I want to highlight here, and one of them is spatial unit analysis. The analysis was conducted at the county level, and there may be a possibility of dampening or averaging out the risk that may be occurring at a granular level. So it's quite interesting to identify which census tracts are more vulnerable, particularly in settings that are geographically large and diverse, counties like on the West Coast. Okay, so, and then another limitation is the statistical algorithms that were used. They insufficiently account for nonlinearity and multiplicative nature of the intricate risk environment that shapes vulnerability to HCV and HIV. So some work has been done to address actually the issue of spatial unit analysis, the spatial unit of analysis, like work by Dr. Kolak, work by Dr. Jednak. It's quite interesting. The piece of work that they have done to address the issue of spatial unit of analysis. Okay, so what I'm trying to come to is how can we leverage machine learning models to assess local area vulnerability. So basically I'm going to run through this real quick. So machine learning models are quite very flexible and complex. So I will show like a conceptual framework that is guiding this work, and you will notice that there is some complexity in this risk environment, the socio-economic environment, the physical environment, as well as accessibility to healthcare. So these machine learning models can handle large data sets, non-linearity, non-parametric and complex interactions between variables. So considering the intricate interplay between the variables that shape the risk environment for HCV or HIV, these models could be suitable in identifying robust, identifying high-risk areas. So, and some work, I think, has been done in the Rhodes Island area to try to identify which census tracts are vulnerable to overdose-related outcomes. So this is the question that I intend to answer, particularly for this work section for my dissertation, is to develop a predictive model that can be able to identify local areas to increase vulnerability of HCV and HIV, and I intend to use census tract data from the Department of Public Health in LA County for cases that have been reported to have HCV under the age of 40 years, because that's as a proxy for injection drug use patterns, as well as integrating it with different risk environment factors that I'm going to show in my conceptual model. Okay, so this is the conceptual model that is guiding my work. It's a little bit complex and I may not go through everything in there, but what I want to highlight here, it's guided by the work that was done by Rhodes, published in 2009, regarding the risk environment framework, as well as work done by Dr. Kolak that I highlighted initially. So it's quite a brilliant piece of work, and it's guiding this conceptual framework that I'm having here. Also, recently, I also did an extensive systematic review trying to identify these different factors that are associated or influence the disparities in HCV outcomes globally. So it's also influencing this kind of flow that I'm showing here. So in summary, what I'm trying to show is that the risk environment factors shaped as socio-economic environment, physical environment, as well as healthcare accessibility, they tend to influence the disparities in HCV outcomes, either directly or indirectly. So directly could be right from here to the outcomes, or indirectly through different individual level factors. Okay, so what's my study area? So the study area is LA, and why do I choose study in LA to try to run this model? It's because LA is geographically large, very diverse, socioeconomically, population density is pretty much high in this area. So, and it has over 272 neighborhoods, 88 incorporated areas or cities, as well as over, I think, 100 unincorporated areas. So it's pretty much a diverse area to try to test out and run this model, which could later on be used in other jurisdictions. Okay, I will just skip this. So this is the analytical workflow that I intend to follow to run my analysis. So it's also a little bit busy, but basically there are 4 main steps: data preparation, predicting the high-risk areas, model validation, and then model output, which is, I think my main focus is here, sharing the data to the community and also the public health department, because not a lot of people may understand what's happening with that model. It's a little bit technical. Yeah, so for data preparation, it will involve a lot of geocoding and linking the data to the census tract level, and also doing some bit of spatial and non-spatial exploratory data analysis. And then for the prediction model, it will involve splitting the data to the training and the testing set. For the training set, it will be to train the model, and then the testing set, it will be to validate the model. I'm wrapping up. Okay. All right, so the results are underway. So this is me also indirectly sending in my application to the organizers of the symposium to welcome me in 2025 so that I share my results. Okay, all right. So the public health significance, basically, I think I've talked about this briefly. It's identifying high-need population or areas, and then guiding place-based and community-tailored interventions like mobile testing, point of care testing, and linkage to treatment. And also, most importantly, the prevention programs like harm reduction service programs are really very relevant if at all we are to address this kind of epidemic. And of course, if the methodology based on how it works, if the performance is good enough, it could also be adopted in different jurisdictions with limited surveillance data related to HCV. Okay, so that will be all. I'm not going to talk about this. It's all about just analysis and how I plan to disseminate the data, the results. These are my references, and welcome questions. Apologies for going over time. Okay, let's start from here.
Hi, sorry, I have 2 questions. So first of all, what make you choose random forest as your model instead of other, for example, linear models? Why you pick this model? Another question is, I saw you have a measurement of your model output. What kind of measurements you can use to evaluate your model's performance?
That's an interesting question, and hopefully I will be able to give a short version of it, and then probably we can talk more about it after my presentation. Is that okay? And so basically, why the random forest model? So the main purpose of choosing random forest model is because of its level of complexity and ability to handle interactions that may occur within their risk environment indicators that I intend to include in my model. However, I intend also to test out other models to validate the performance of the random forest model compared to other machine learning models. And so that's what I intend to do. So you had a second question?
Sorry, I just wonder what kind of measurements you can do after your model get output to evaluate your model.
For model validation, right? Yeah, so for model validation, one, I intend to use machine learning validation techniques like area under the curve, AUC, as well as the root mean square. So I will try to compare the two and see what works better. Okay. Yeah. So and we can talk more about it probably after my talk. Is it okay? Thank you very much. Yes, please.
Yeah, I have a question about fantastic talk. It's super interesting. How did you decide on census tracts? So you say counties might be too big, but are census tracts too small? And then also, how did you think about mobility in space? Because if I understand it, like your training data is cases of HIV but people might move, like, if you think about like where in LA County should we put like a safe needle exchange? But if people are moving around, like if your case is in Santa Monica, but they are using drug in Venice, so like, how are you thinking about that?
Actually, that's a great question, which we are still talking more about it, how to address that particular aspect of mobility, because it's very complex to handle. Probably some assumptions will have to be made regarding that. But to your first question regarding the census tract levels, of course, it's the smallest neighborhood level. However, what we are planning, me and my advisors talking about, is how can we also try to think about the ability to use typology or regionalization approaches to try to be able to come up maybe with other forms of neighborhoods that may work better in our analysis. So that's still something that we are thinking about as we are diving into data analysis. Thank you. So,
A question about the code that you're using.
Second,
The
please.
software that you're using to develop your machine learning models.
Ask again, please.
The software.
The software that you're using.
Oh, the software is interesting. So I intend to run my analysis using R software. Yeah. And then, of course, the visualization and mapping, I will do that in ArcGIS.
Okay.
For some questions that we can check for after everything. Okay, thank you very much.
This one's yours, right? Yes.
Alrighty, so last but certainly not least, I'd like to introduce our next speaker, Anika Perez, who will be presenting. Anika, sorry. My accent's gone, I've been in the Midwest too long. Anika Perez, who will be presenting a talk on urban spaces in San Diego, California.
All right, hello everyone. My name is Anika and I am a incoming fourth year PhD student in the Department of Geography in the joint doctoral program at San Diego State and UC Santa Barbara. And this is an ongoing research that we teamed up with the biology department at San Diego State. And also we got $1 million grant by the USDA. So this is a really important project and it's very significant. So let's get started. All right, so this is just sort of the outline how I will be introducing the research. All right, so there has been numerous research that we have heard that community gardens are very beneficial. It increases physical activity for residents, access to organic food when there's food deserts. It improves mental health, especially if you're touching the dirt. There's some sort of reaction whenever you do that. It builds community and social resilience, so it brings everyone together. And it also adds green spaces in cities, which targets the urban heat island effect. However, in 2012, Nathan McClintock, he's a famous geographer, and he did a study where because urban agriculture is increasing in cities and we have vacant lands and abandoned lots, many of these cities are having this urban renewal where we're having more, establishment of community gardens. However, many of these vacant lots are actually previous brownfield sites. They're right next to industrialization. They're right next to freeways. And so who are actually getting the benefits of community gardens? So he did his research in Oakland, California, a predominantly African-American population and low income. And so he was able to find that there was actually high levels of PV exposure to these communities compared to the white communities and the higher income communities. And so this really influenced me and what I really want to focus on. Do community gardens actually provide benefits to all? And so there has been numerous research that has found that, community gardens may provide benefits to some people according to race, class, historical, and the continuation of land use and zoning policies that happen in the United States, and also segregation and redlining. And so on the map, you can see that that's actually a map of San Diego of the HOLC grades of areas that were really disinvested. And so my argument is, what does the role of urban neoliberalism actually mean here? And so neoliberalism really fosters like a market-driven approach into which they want people to have this individualism, to be able to do things on their own. So instead of actually targeting this systemic issue, they want their own members, their own community members to do it themselves. So they want people to obtain permits, to secure the land, to get all this activism going on, when really the local government should be doing something in order to help these people. And so the problem with neoliberalism is that it has the privatization of public spaces. So it basically means that it limits access to people who could have who could go into these green spaces. And then it also causes gentrification and displacement. So when we start putting these community gardens in these spaces, we start cleaning up the neighborhood. So what does that mean? So we have new investments going on into these communities. We start pushing the lower income and POC out, and we start bringing these gentrifiers instead. So we start raising the property values. And then also, like I said, the marketization of community gardens, that often means who has access to these community gardens? Because whenever you go to a community garden, you have to have some sort of membership. How much money are they charging? They're not cheap, and usually they take a year long to get access to these community gardens. And then public funding, we have to rely on resources from the city. So are the city going to give us this land? Do we have to make deals with the land ownerships? What's going on there? And like I said, individualism. So people have to have their own community involvement in order to get these spaces. And so this is just an example of one of the gardens that we have in San Diego County, which is right next to the Tijuana River. It's on the border state. And so one of the questions that I am targeting are the disparities in neighborhood access to community gardens. What are the disparities in neighborhood access to community gardens by race, ethnicity, and class in San Diego? What are the policy and planning decisions that have shaped or previously shaped are continuing to shaping this uneven geographic urban landscape? And so really within this research question, I'm trying to look into the zoning and land use regulations that is going on, the resource allocation, the environmental sustainability, the social equity that plays a role in this, and the health implications. And so one of the ways that I am approaching this research is environmental justice and political ecology. And so urban agriculture is socially and politically produced through racially based policies, investments, and ideologies. Political ecology really looks into the political, economic, and social roles that play within the city and the environmental issues. So I'm going to try to combine environmental justice and political ecology within this research. Law and policy, like I mentioned, I will be looking into what kind of laws have been playing a role. What is the city of San Diego doing? Are they going to target any of these issues, or are they just going to continue to ignore them? And then the exposure science epidemiology, who is getting affected by these community gardens? How much lead is there going on? Because I know the EPA has certain standards about lead, but just saying no amount of lead is actually safe. It's actually very dangerous for you. There's actually a lot of health risk on it. So the study site, San Diego County, the finest city in America. It is a really pretty city. I'm not gonna lie. We have our beaches, our best weather, but San Diego it's a border county, so it's right next to Mexico. So we have all of this military industrialization, international trade going on, and it's also very diverse. We have a large population of Hispanic or Latin American people. A lot of them are also immigrants that we have there. About 11.4% of them are actually below the poverty status. So that we also have our segregation between the coastal areas where it's mostly higher income, and then more inland is actually lower income. And so in 2022, San Diego promoted the Climate Action Plan, and that is to kind of target our sustainability initiatives with California in order to go more green, more sustainable, more energy efficiency. And then the state of California also passed the Assembly Bill 551, the Urban Agriculture Incentive Zone, which really gives landowners a tax break if you allow to rent that empty space for community gardens. And so urban greening is a solution to neighborhood disinvestment. So like I said, San Diego generates a lot of money from military, tourism, international trade, and manufacturing. But where's the money actually going? Is that any money going into these communities that are in need? So why is this important? Like I said, this is a racial and social segregation that is going on in San Diego. It's giving to limited access to employment opportunities, housing affordability. I'm sure you guys have heard that California is super expensive to live. Many people are getting pushed out because of how expensive it's getting there. Education and healthcare, not everyone has access to education and healthcare in California. And so one of the goals with the San Diego Climate Action Plan is that they want to increase urban agriculture throughout the county. They want to be able to give more community gardens to people in order to target food deserts, but also to give sort of I'm sorry that we kind of pushed you guys out, so here's a green space for you. And so there are a total of 70 community gardens in San Diego. And this is just community gardens. We're not focusing on urban farms or community gardens in schools or churches. This is just community gardens that work with neighborhoods. And so in June 2011, San Diego passed an ordinance that allowed residents to get a community garden permit without all the expensive prices that you have to pay. Many of the community gardens are actually clustered in high populations of immigrants and Latinos, and that's mostly in the urban core dense areas. So there is a socioeconomic landscape that really defines where are we placing these community gardens. So one of the methods that I'll be using is GIS mapping and storytelling. I'll be also using neighborhood and garden profile, which this would include the US Census. I will be using interview and coding with NVivo and snowball sampling. And I will also be doing the soil and environmental analysis. And so for the soil collection process, we were actually able to get a team of undergrad biology students where they went out to the community gardens and collected soil samples for us. We didn't give them anything fancy, just little like sandwich bags to collect soil samples for us. So we collected a total of 70 with all the community gardens. I don't know this part. I am not a biologist. I am only going to wait for the results, but this is kind of the process of what the team is doing to get that. And so this is some of the maps that I created. So if you look at the left side is the census tracts of Latino populations in San Diego County. As you guys could see, most of the garden sites are actually located where there is a dense population of Hispanics and Latinos. Most of the white areas are actually where there is higher income and white populations. On the right side map is actually the historical redlining and HOLC grade that we have in San Diego County. As you can see, most of the urban core of San Diego is actually where we have the community gardens. The ones with the A grade is the best, where there was most investment. So as you can see in the very corner, the green, that is La Jolla. La Jolla is very famous for being a very rich and white community. And then you got where the D grade is, the most hazardous. That is actually where most of the Hispanic and Latino and immigrant populations are situated in San Diego. And so, like I said, San Diego does deal with a lot of unhealthy air quality, water quality, noise pollution, and traffic congestion. And that comes from a lot of things, especially, like I said, we do have a lot of military going on in San Diego. And actually in one of the neighborhoods, there's actually military bombing. And so I wonder why they could get away with that. But so why am I focusing on lead? Because of the industrialization that is going on in San Diego. Is there an unequal exposure to contamination? So far with the EPA standards that we have seen, the black areas show where there is mostly high risk to lead, and it's mostly where all the Hispanic populations are also situated in. And so one of the things that I wanted to talk about with one of my methods is decolonizing the map. Although I'm using GIS, you know, as being in the science field, we tend to only want numbers. We only want stats, but sometimes I feel like that is very irrelevant when you're not considering people's lived experiences and what they get to see every single day. So one of the things that I'm going to do is I'm trying to target this whole white supremacy of continuing of the exploitation and injustice of these communities. And so what I have established a lot of relationships with these people. You know, I've been to their city councils, I've been to their volunteer work, and one of the things is that they want their voices to be heard. And so one of my goals is to really do a storytelling mapping, and that is basically where you get this big piece of paper and you let these people map out what that place means to them. So that could either be like maybe plotting what the location of the community garden means. What does the community garden provide to them? What does it not provide to them? What would they like to see different around that area? And so one of the reasons why I really want to do this is because I really want to fight against this whole like systematic like science kind of thing. All right, and then almost done. So one of the main things that I really want to focus is urban renewal, greening projects, and their effects in cities. You know, the historical disinvestment and racial discrimination that is going on with this. You know, who has access to these spaces? How come it always has to be community responsibility? Why isn't it the local city government doing anything, or people with power? What about the quality of the land and the soil? Who's getting more exposed to PV? How is it affecting them? Have you noticed any like things about it? And I also want to just point out, you know, many of these like Hispanic and Latino people come from indigenous roots. You know, my grandma is also Mayan. She speaks the Mayan language. And we tend to think that people without education, without any degrees, don't have like some sort of knowledge. But they know. I've talked to these people. They know that there is contamination. But the problem is that there's no resources. No one is actually making an effort to help these people out. So they're just getting ignored. And so what are they supposed to do? They want to go out and build their neighborhood, you know, community establishment. They want to be in these green spaces. But when we don't have that sort of resources, what are they left with? So I think sometimes we tend to overlook that there is indigenous knowledge within these spaces. And then so because my research is a doctoral dissertation, I do plan on doing 3 peer review articles. So the next steps is really to target the 2 other research questions that I have in my research. First, I have to survive my qualifying exams. That's in August. So wish me luck. But yeah, that's one of the things that I hope to do. My references, data sets that I use for this GIS project. You know, and I do want to thank my committee members. They're the ones who really have helped me a lot. I know someone mentioned Dr. David Pello. He is in my committee. He's a very big critical environmental justice researcher, so I'm very lucky to have him. But if anyone has questions, let me know, and I'm sorry.
Well, I guess people can also talk to you.
Yeah, whenever.
Great. Awesome. Thank you so very much.
So we do have a 10-minute break, and we are gonna come back at exactly 4:40 for our pisha. Okay.
Also, if anyone's missing an iPhone with a horse on it, I got it.
Oh my gosh.
I'm also missing a blog. I left it somewhere.
I don't know where that is.
Yeah, it's okay. I'll find one somewhere.
Oh, I can.
Okay. I'm glad you took it out because I was wondering if people were like sharing with the StreamYard, but you did.
Yeah, I got it.
Yeah, you know.
So that's true. That more than.
I'm also, I'm also taking my house.
I know you are.
Yeah.
No, of course, I feel
It's one of the things that
Oh, yeah. Oh,
Enjoy being a
Oh, okay, good. Okay, so I was told that in the website. Where are you from? Ooh, I love Japanese food. Okay, so where do we go for Japanese food? And I really know nothing. What is your favorite ramen place? Can I
They're all in order from left to right. And so what we'll do a slideshow, and then down here, we'll go to autoplay, and then every 10 seconds, there is no 20-second option for Google Slides. So what we have to do is do every 10 seconds, and there's 2 of every slide. So it'll auto advance. No one else will notice because it'll be the same slide still. And then in total, 20 seconds. Google really, apparently, I don't know why Google didn't do this, but yeah. So yeah, you switch to every 10 seconds, and then you just, like after you do this, like, be like, go, and then you hit play, and do this thing. So yeah, that's it.
Okay, so and you said it's already in order.
Everything's in order from, yeah, it's 1, 2, 3, 4. So they're all in order, and then you just hit slideshow, and go down here, play, every 10 seconds.
Nice.
And use that on the back.
So I think it's going really good.
I would hope so. The bar person is set to come any second now. kind of nervous that they're not here already. Yeah, they should be. Marcus coming in a second now, and then after that it's. Yeah, and then after that, after that section, we'll be good. That's it. After reception, we're done. We pack everything up, and that's it.
Alrighty, thank you. Sorry.
I'm driving me nuts how it's, you can see all of this, and we can't download the PDF and stream it. That will mess it up, right?
I don't think so.
There's no options to use your full view. It's so weird.
I think it's because it's the YouTube streaming. That's just how it's going to work.
Yeah, because we were able to figure out how to do it otherwise. It's so annoying. Okay. Yeah.
Looks perfect for them.
Oh, I see. Okay. Okay, well, that's something. So the version that gets recorded has the perfect version.
Yeah. I don't think anyone seems to be minding.
Well, they wouldn't say that. You know what I mean?
But also,
it's only people like me.
Yeah, no, me and Shabam also thought it was like, hey, anyway. I'm like, no. But also, yeah, everything is set up for the
Can we add some Pachaka music?
No.
Oh no, we don't have time.
They're timed, but sometimes
So it works to do it from there.
yes. But I did it on Catherine's. I did it on the channel. Why didn't it update?
Sorry. But at least we'll actually go here for slideshow because then we can time it that way.
Yes, but here's the thing. I edited everyone because the slideshows here, they do not do 10 seconds, or they only go up to like 15 seconds, which is a problem. So what I did was I duplicated all of the slides, and then played for 10 seconds, and so each slide would get 20 seconds.
But no one's gonna notice.
Yeah, no one will notice. Like it tested everything, but for some reason, it didn't save the
duplicate. Notice the slides got duplicated on accident, so we deleted all this.
Yeah, because I was like, this doesn't look duplicated to me.
Because you check the slides, you're like, two of all the slides.
No, but then you can go to the history,
Oh my god, we can?
right? Yeah.
I'm sorry.
Go to
No, your
Version.
That makes more sense.
version history. From Catherine Sentence.
Oh, just do 30 seconds because it's more. There you go.
There we go.
I want it done.
Store this version.
We fixed it.
I'm so sorry.
You're all good.
I have no idea. I don't know about any of that stuff. That's so funny.
Yeah.
That's really funny.
I'm glad you said that. It would have been really awkward.
Oh my god, that's so funny. I love how Mark was like, it's not funny.
And is it possible to show the speaker that I see my notes, but like
I
you know?
So maybe these are fine. I have to double check. Maybe I'm sure there's a speaker view.
Because if you go on slideshow and then speakers view, so I see my notes, but not like
Right.
the rest.
Yeah, I'm gonna double check. I'm pretty sure it's possible. Just there we go.
But I think that it's good now.
It's good now.
And then for you wanted your speaker now. Yes.
Presenter view. Oh no.
No, I don't think it'll work with the because they're also streaming.
Oh no.
Yeah, so here, so they're streaming. So on,
It's actually here, but it shows on YouTube.
so here it's gonna show, but it won't show here.
Yeah, like in person. Like we'll see your notes basically.
Okay.
Yeah.
Oh yeah, so it doesn't look like that.
You could pull up on your phone, but you just
But I only have two less time, 20 seconds. I'm like,
yeah. Well, think of it this way: if you forget something, it's gonna no one's gonna know.
So it's background.
I would try to improvise.
No, try to say your name again.
Xenia.
Yes, Xenia. Okay.
I have to redo the screen share. But at least for the Google Talks, it'll work. So for ours, it'll look normal on the screens, but then for the other
So is it Asker?
Yeah.
Asker.
Oh, that's beautiful. I had it set up so that it would work in a second. Do you want to screen this tab? Where do you can't just do the entire screen. Can we just do that?
Sure.
Yeah.
Oh, well, there we go.
And then, but then double check that it's on screen. Shown properly.
You got 4 minutes.
Okay, awesome. And then start every 10 seconds, right?
Yep.
Okay, so
Hey, it's a party. Great. Alrighty.
Greetings and salutations yet again. It's me, one of your lovely hosts, ready to get started with the Pashakasha. Yes, our lightning talk. So the order is as follows. Well, first let me tell people who don't know what exactly this is. It is a lightning session. We will have 4 speakers. Lightning, literally, they will be going fast, 20 seconds each slide, and it just goes automatically. So this is the order that we'll be going in. Asker, which is first, Michael, Marinia, and Xenia. Okay, ready? Let's begin. Oh, prepare. Okay.
Awesome. So hello everyone, good afternoon. I don't think I have any time to introduce myself. I am Asker, currently working as a GIS analyst. I've been working at Policy Center. It's a part of Indiana University, and the 20-second did not run out. So I did my PhD in, okay. So go back to the presentation. So this is the current outline. I'll be talking about one of the report we have been working, that's State of Aging Central Indiana. So we have been focusing on the older adult population who are living in the central Indiana and how their different socioeconomic and environmental condition has been affecting by aging, the social determinant of health variables. Okay. So why you need to talk about the older adult population? You can see the demography. All of us at some point will be the older adult population, right? So as the younger generation, we need to do something about them. So it's a good point and good starting point. In terms of like demography, they include 25% of the total population. That's a big number. In addition, they have a different needs. So the pyramid you can see, there is like a higher number of female population as they go older because they have a higher life expectancy. So that's another area we need to focus on since they have like a more different kind of need than the male population. In the household, we can see there are some differences based on the race. For example, the Black and Latinx population, they used to live a little bit more than with their grandchildren compared to the white population. In addition to that, the more longer they live, they become like single or like separated or they are living alone. So they have like a special kinds of need which we need to focus. Income is another aspect. So this is like the survey which talk about like the living cost at the India area. You can see from there both like the male and female population by age 65, they have like a lower income than the cost of living. So that another area is like an important and significant one. Housing, another issue. We talk about like housing cost burden, how much they are spending their income on housing. So you can see most of the older adult population as they go older, they're spending more of their income in the housing. In addition to that, they have like different needs, income like rent payment, housing search. So those are like some of the areas we need to focus on. In terms of like food security, many older adult population, they are living to the center, which is like highly like a little bit less access to the food area, and also sometimes they do not have like the transportation, which will be focusing on the next slide. Like it is difficult for them to drive to a center to get the food. Sometimes they're living alone, so there's like no one there. So all the time the travel density is like more to the center area, but as you go like more to the rural areas, there's like a lack of public transportation, which also makes them like really difficult to access like different goods. Density is a factor. In terms of like social capital, sometimes when they get more older, there is like a less amount of activities in terms of like community gathering or participation. So they differ both in terms of like social capital index, which is kind of really important because you need to know like how they are doing, and in many cases they are just like living alone. There is like no one to take care of them or like talk about them. In terms of like health, COVID makes a huge impact. We all know about that. But again, like compared to the years, like all the areas, the mortality kind of like higher, but in the recent time it actually decreased. But after the COVID, we can see like another surge, and that's like common pattern for Indiana, Central Indiana, and like other areas too. This just shows like what are the top 7 causes of mortality. Again, like the heart disease was the rank #1 for Central Indiana, followed by cancer, and COVID is not longer, but we can focus on like chronic respiratory disease. That those may differ by male and female, which I haven't shown here, but later. What we are showing here, the condition that differ like for male and female, for male population, you can see like more chronic condition like diabetes is a little bit more familiar, but for female, it is more like neurological condition, including Alzheimer and depression is a little bit more frequent to the male population. So all that say like we need to have a different kind of strategy when you're talking about like older adult population because it varies with male, female, and also like the racial population. This slide is kind of like talking about the importance of like mental health. The CSOC survey, they are talking about this. Many of them, they do not have like access to the different resources, which include both the medical and physical and mental health. Here, you can see the graph. So from the graph, anyone can say like, hey, the number of physicians has been grown up compared to 2015. But when you see the number of physicians who are specialized on older adult population, it actually getting decreased. So that's kind of like a concerning thing in terms of like resources. We also talk about like caregiver. This and the next slide will talk about like many of the older adults, they are responsible for their grandchildren. So sometimes they get like a little bit more stressed out in terms of like income and like giving responses and like meeting their needs. So some of the key takeaways from those slides, just to summarize, for basic needs, many older adult population, they are deprived of their basic needs, and in many cases they don't know how to get them, how to get those access, how to get those resources. So there's like a lack of awareness among them, and there's literally like very less amount of programs that talk about that. Living in the community that follows actually the same pattern. Many of those have like a loneliness or like lack of social capital, social isolation. There has been a lack of initiative that's focusing on those aspects too. Also, there need to be like more program on mental health and reaching out to them, like how they are doing, what we can do about it. And finally, health and wellness. Again, there has been like a lot of disparities, not just like on a single lens. It varies with male-female population. It varies with racial group. So we need to think about like the different strategy to reach out to them and talk out to them and do something about it. So I think this is almost done. This one is not finishing. If you wanted to read more about those indicators, different section of the report, go to the URL. Each of those, like I just shows 2% of what is in there. So there are like a lot of chapters that talk about each of those individuals more there, elaborately. So go to the link, access the report, and please let us know what you think about it, or if you want to discuss more. Thank you. It is 6 minutes.
Oh, yeah. Oh, 2 minutes. Yes. Questions. Yes.
Oh.
Sorry.
So good. I just did some work on suicide mortality, and there has been an increase since COVID. And in Chicago, it plays a little bit different, but overall in the United States, it's up for older people. All those reasons that you said, the isolation is really, 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 really bad. So the Surgeon General, which is from India, he's Vivek Murthy. He spoke at the London's, well, it's not, but it was in London, the World Happiness Summit, extensively on young people and older people with suicide mortality. So like all those things that you.
Yeah, so this like kind of shows a snapshot for Central Indiana. We are like really interested in know like how other areas have been doing compared to the Central Indiana. So maybe like in future we'll have like more collaborator, maybe working with like different groups and different institutions at other university, like to think about how we can like have this framework and see how your area is doing. So definitely like we're open for that, and any suggestion, any feedback, just let us know.
Awesome.
Anything else?
I know it keeps the energy up. I don't think so. Does it? Do I need to hit
Oh,
players?
you know what? It's me who has to do something else. It's me. Okay.
Someone shout out the neighborhood you think has the highest SNAP redemption rate in the city of Chicago.
Belmont Creek.
The Loop.
Yeah.
SNAP redemption. My name is Michael Lutzpike-Udall. I am a rural sociologist, research assistant professor at the University of Illinois Urbana-Champaign, and affiliated with Illinois Extension. What I'm interested in is different ways we can use machine learning to look at concentration of census tracts to better define neighborhood areas. So the neighborhood effect specifically explores how social and economic factors, environmental factors within defined spatial units impact individual outcomes. Traditional administrative boundaries like counties and census tracts fail to accurately capture lived social spaces. So predecessors in rural sociology have looked at structural place poverty theories and advocate for the analysis of complete activity spaces of individuals, which emphasize local economic areas and rural communities, which often involve commuting across county boundaries. Utilizing labor market areas and hierarchical cluster analysis at finer geographic scales will help us create a more accurate representation of how different rural social determinants of health fulfill the full activity space of where people both live and work. So by specifically looking at clustering census tracts and linkage data, how can we better define these neighborhood effects? By looking at both origin and destination data, as well as taking into consideration the geographic distance between these places. So spatial scale and boundary decisions can really impact the way that we look at neighborhood effects based on scale and zonation. So when we talk about things like the modifiable aerial unit problem, the neighborhood effect averaging problem, and the uncertain geographic context problem. Hierarchical cluster analysis to basically construct clusters of tracts that represent local neighborhoods in rural areas. This is definitely, I've been chewed out by reviewers, a more traditional approach to community detection. This is how we did it in the 90s as rural sociologists. This is how we're still doing it. So the LEHD is administrative data, so it specifically captures using unemployment insurance data where people live and where they work. It provides a comprehensive suite of data products through the US Census Bureau to talk about workforce dynamics. The benefit of this over the ACS is that it's using administrative records rather than self-reporting because you can't trust people to accurately report where they work. This is an example of frequencies of commuting patterns between different census tracts in the city of Champaign, Illinois. I originally did a two-dimensional home and work. My reviewer too told me that was not acceptable. I needed to move into the metaverse and add a third dimension to my distance matrix. Here is an example. You see people commuting from the affluent section of Champaign to the university. And then you see this area in another map stay in this area, and they're not touching each other. So the affluent people are staying by affluent, service industry staying by service industry. This is just hierarchical cluster analysis. For some reason now that's called unsupervised machine learning. I use a SAS workstation for data processing. I ended up using a server instance. I said R, but I use SAS, and basically use a dendrogram to delineate these hierarchically. So in this paper, I don't propose any specific delineation, but I basically provide different levels of clustering or distance thresholds, and then within those show the average populations within the cluster, as well as the relationship between the distance threshold, mean, and median of tracks within each cluster. And then we have maps. So you see here with these dashed lines, all of these community areas clustered together. These community areas clustered together. This is the university. Those are the students. That's farmland. There's no students that live out in the cornfields yet. Yeah, so I call those neighborhoods. Here's an example of how it would look in Chicago, Illinois, even though this method is primarily, we developed it because we needed rural food environments. Quiet is better. Northern Chicagoland. You notice in the more affluent areas, we have a much larger clustering. So you notice here in Northern Lake County, a lot of people commuting all over the place. My home, Quad Cities. So one of the other things you'll notice is there's some jumping that's happening here. So there's manufacturing. John Deere's located there. And then there's a lot of people commuting from like Milan to there, so the spatial units are jumping, and that's one of the concerns that the reviewer too had. I argue they don't need to be contiguous units, but whatever. Western Illinois. And you see this is where it's really helpful because it's showing us where people are commuting from these more rural areas into the urban areas, and different areas that might be potential food environments. East St. Louis metropolitan area. So here's one of the examples we see. North Las Vegas does this as well, but North Fort Worth, well, some of these areas with new construction, it's actually clustering 119 different tracks together. So again, that's something that I'm kind of trying to tease out as to, that's a lot of tracks that are getting shoved together in terms of like relationship between the spaces. So in sum, we use a proportional flow methodology to take a different approach to delineating neighborhood areas using publicly available data. This might provide one solution to address contextual fallacies in ecological space measures when we're doing hierarchical linear modeling. But yeah, we've delineated 16,812 neighborhood area units at a level of about 250 on the dendrogram. However, other researchers might choose to do something else based on what works for them. And despite the advancement of being able to cluster these census tracts together, it does introduce significant challenges for lay researchers in both the instability of tract boundaries and the nuances of the data that we continue to distill. Because this data is not designed to be used for this, there are some weird nuances in the unemployment administrative data. imputation of values, disclosure avoidance techniques, and the social implications of who does and does not commute to work, and has access to transportation resources. So those are additional things that we can actually tease out with the LEHD data. Also, this took a freaking long time to compute. So the procedure ran at NCSA for 292 hours with multi-threading. So still not going to give up SAS. I love SAS. I'm a rural sociologist. We wrote SAS.
Please kind of stop. Thank you.
State is a ripoff of SAS. Go ahead.
So, where does the commuting data come from? Like, how did they track that?
Yeah, so the commuting data is publicly available and I encourage everyone to work with it. It's from the Longitudinal Employer Household Dynamics System, something or other, but it's a series of data sets that's basically produced by the US Census Bureau. And it's typically used for like the CTTP, so the CTPP, Census Transportation Planning Program. So there are other uses of it to delineate metro and micro areas. Also, this is citable because it has an R&R right now in demography, so I have no problem sending it to you. So yeah, thank you.
Yeah, I can take one more question.
Well, go ahead.
How would you validate the neighborhood you have defined? Have you ever compared with other existing neighborhoods?
Yeah, so we want to look at validity against the American Community Survey. I haven't gotten to that point in the RDC just yet. Also, as a sociologist, I don't do stuff as good as geographers do. I just put stuff into the computer and run what proc factor, I don't even remember what the proc command was. Anyway, SAS.
Thank you so much. Awesome. Perfect.
All right, I had not practiced this very much, so this will be a game to see how off I am. All right, I kind of feel like I have to be this has to be on my left-hand side. Okay.
Oh, great.
Okay. That won't work. Okay, I'm safely behind this table. And we're already going, right?
Yeah.
Okay, I'm Marinia. I'm from U of I, and the opioid epidemic. More than 760,000 people have died since 1999 from a drug overdose. Nearly 75% of drug overdose deaths in the year of the pandemic involved an opioid. And my big goal is for all of you to believe that thoughts and prayers won't stop opioid addiction. There's actually evidence-based medication and other things that can support it. So despite there being evidence-based medication that prevents premature deaths, only 20% of persons who have opioid use disorder access it. So that can vary really widely. In some areas, especially like rural areas or suburban places, far, far fewer. There are multiple barriers to accessing MOUD medications for opioid use disorder. But it turns out that the measurement of how we measure spatial access to these resources is still not completely well understood yet. There's a lot of research out there, but there's also a huge variability of measurements. Please all look over here at Dr. Wataru Morioka. You'll be coming back to him a little bit later because he helped with some of this. So what are the evidence-based medications? Methadone, that's a full agonist, one of the most successful medications, also has the highest stigma. Well, what's up with that? And here we can see methadone, very effective compared to control. Buprenorphine, also incredibly effective. Naltrexone is the least effective, also has the least stigma attached to it. And again, the vast majority of people who use opioids or misuse opioids do not have access or don't access these medications for a number of different reasons. There's also a lot of other critical resources like naloxone, that's an overdose reversal, syringe access, which actually, if you treat people like humans, who are humans, it turns out that that's better for their health and a whole bunch of other things. So access to, I know, it's a big shock. So it turns out harm reduction practices like access to medications and lots of other things that save lives. Compared to something like end-stage renal disease, 750,000 people are able to access dialysis, whereas the far minority of folks, there's many, many more people who have opioid use disorder, and a tiny fraction of those are accessing medications. It is complicated, right? So methadone may not be, there might be providers, but they might not be accepting more patients. They tend to take cash, but it can vary. Buprenorphine, a little bit different. It's really complicated. So when we're measuring access, we have to think about who needs it. Who is the population in need? What's our denominator? Can we measure it? So this might be the total population. It could be folks who tend to be younger, because a lot of the folks who are dying prematurely tend to be middle-aged or younger. So a human rights view, I argue, will look at the whole population or potentially adult population or 16 plus. Potentially you want to focus on those at highest risk, look at areas that have high rates of fatal overdoses or hepatitis C, acute injection drug use. We don't have the exact population of people who are misusing, and that also kind of, anyone potentially could have opioid use disorder. So how is each medication accessed? Some are very expensive. Naltrexone, highest stigma, or lowest stigma, least, what do you call it?
Effective.
Least effective, the most expensive. This is the US. Okay, what is good access? Our team thinks that over an hour and a half is probably unreasonable. Think about this as grocery store, accessing groceries. Methadone, you might need to access it daily or weekly, especially in the first few weeks and months. So traveling an hour is not going to be realistic to long-term effectiveness. So there's also issues of transportation, financial resources, and then stigma ends up being a really big factor of this. And there's many different types of stigma. It can be from being not treated well at the doctor's office. It could be from friends or relations not believing that the medication is useful or that you should have a right to access it. Our team previously found that places that actually had more places with medication for opioid use disorder also didn't have as much stigma across other dimensions. So it's really complicated. Our team studies this with all the contextual data attached to this. So we run a national center for NIDA and NIH to provide this information for free to anyone, multiple clinical groups. There's over 100 different data sets. Ashlyn over there helped a lot with that cleaning and will be doing more this summer. So big thank you. And there's many different types of aspects to spatial access. Spatial resolution, temporal resolution, which distance measure, which access measure. This gets geographers really riled up. Boundary conditions. Can you take if you're a jail, you can't take people across state boundaries. So there's a lot of different factors. Here's just one measure for buprenorphine. 6 different metrics, 6 completely different maps, okay? So RAM, the fanciest gravity model at the very end actually has the most variability, and that actually is probably the best for different regression models. But it also depends on, are you in urban, suburban, and rural areas? To follow on Michael's vote previously, there's so much focus on urban analytics and access that we're completely missing how to measure suburban and rural access, and that's a huge issue. So the last 2 maps, thank you, Dr. Moriarty. And last slide here, just one of the metrics we looked at, let's look at co-location. So areas that have high mortality over the past 10 years and the worst access, it's a very different map than some of the areas. So yes, we're getting West Virginia and the Appalachians, but First Nation communities are getting hit the hardest, and they're not often talked about in the national audience. So that's it. Thank you.
I feel like running a mile now. Yeah.
I don't have a question. I just want to create a quote, treat people like humans. That was awesome. I like t-shirt.
It's a shock.
Can we get a t-shirt next time? People like humans? No.
Especially, I think, on the data science analytical side, I think it's a huge responsibility for all of us to come back to that realization that yeah, people are humans.
I think my comment versus question is just that stigmatization of any of these problems that we've been talking about is just underrated as a barrier to actually solving problems. So I just wanted to highlight that.
And it's 100% driving a lot of the outcomes too. So like I know for opioids, there's a lot of research showing how like if you're like stigma leads to higher overdose rates and a lot of other things. So there's many reasons, right?
Awesome job.
It was an awesome presentation. I actually work in the Bureau of Behavioral Health, opiate overdose, violence, and mental health. But this data is amazing. However, if we stick too much in the end stage of public health, then we're missing why someone is going to try the opioids in the first place. So if the young people want to go to university, like all you people here, I mean, obviously like the PhD and everything, right? Then we don't have to worry about that person. So it's like the other side of the street, like both. But
100%.
sometimes as data people, we don't think about the other side. So it's like, not to say like this qualitative, both are important, because when I was at the medical examiner's office reviewing all the deaths from opiate overdoses, there are times when we read the narrative and there was a brother who, it says the narrative, like the brother already died of opiate overdose, and then now a few months later, the brother is, or the kid is, like, so there's a lot of things in the data that we could,
100%. And disclaimer, I'm a person with lived experiences with this, where family members who are very close have, passed away to this. So I'm a little biased too on the human aspect as well. But to your point, actually that center that I was talking about, the opioid environment policy scan, the whole purpose of that is to bring in the community context to understand what are the kind of preliminary factors that are driving the outcomes way before like those end stages. So if we just focus, harm reduction is incredibly important, but there's also that whole policy upstream factor, which is critical, right? And I've been to also regional science conferences with a lot of folks from economics there, and it's really interesting because they're not like I think those teams have to kind of come together a bit more to speak the same language, right?
I guess no, but it's not. How should I? There you go.
All right, so hi, my name is Xenia. I'm currently a visiting scholar at UIUC at the Care Lab, but actually I'm from Vienna and do my PhD in ecological economics at Economics University there. And now I will present current work, Spaces of Environmental Inequality, where I try to map the intersections between socioeconomic disparities, the environment, and policy. So to give you some background, I'm interested in how socioeconomic inequalities and environmental issues are connected and how to reduce inequalities while also protecting the environment. Why is this important? Because we observe increasing socioeconomic inequalities as well as environmental pressures, which call for eco-social policy. So the first problem we face is that environmental threats, as for example, air pollution, but also environmental goods, for example, the access to green space are socioeconomically unequally distributed between countries, within countries, but also between households with different socioeconomic backgrounds. Colleagues and I recently published a paper where we, for example, showed the socioeconomically vulnerable neighborhoods in terms of income, nationality, but also education are exposed to higher levels of particulate matter than neighborhoods which are better off. And this was true for urban as well as for rural regions. The second problem we face are impact inequalities, so also this responsibility for environmental pollution is unequally distributed. This is also true for countries, for regions, but also on the household level. When we look at industry, at the industry level or facilities, we recently also with colleagues conducted a research where we found that the top 100 facilities in Europe cause the majority of industrial pollution, CO2 pollution, as well as billions of years of health damage costs. And these are only 100 facilities. So we see that empirical studies show that environmental hazards, those amenities are unequally distributed. And the question is what we do now with all these empirical results, how to contextualize them, to translate them, to communicate them in order to implement and develop policies which not only include social justice but also sustainability. So far, I've worked a lot with environmental justice literature, but I argue that the concept is a bit lacking in several aspects. So what I try to do now is to introduce new approaches, as for example, political equality, it was mentioned in the earlier presentation, and to introduce newer spaces. So that's where my project comes in. With multidisciplinary mapping, I will try to introduce these new spatial narratives, these new spatial layers to environmental justice in order to contextualize what we already know and to implement it in practice. What do I mean with multidisciplinary mapping? Beyond Euclidean coordinates, mapping as a collaborative effort to collect and display qualitative as well as quantitative information, but also mapping of multiple layers. So not only metric, not only the data, but also the meaning. What do we mean with this data? What does this data mean? So I construct, so to say, 3 different layers. The conceptual layer, which includes, so to say, the meaning, theory, concepts, the operational layer, and then the factual layer, the data layer. So yes, so it's maybe only a beginning, maybe some more layers will come, will be added. What are the underlying questions which motivate these layers? So for the first, how and why do inequality and the environment intersect? What dimensions of environmental inequality can be empirically identified and how can we measure them? And finally, how to cartographically visualize and communicate them. Speaking a bit of the methods, for the first 2 layers, I apply mainly literature analysis, and the second layer and the third layer is the spatial GIS analysis, and all 3 layers are based on or informed by a case study. To mention this case study quickly, because we'll hear, I think, a great presentation about this tomorrow. But this is one of the case studies which really inspires my work, motivates my work. And that's Jive's data collaborative and community mapping application. But yeah, I will not talk more about this because I have no time, and we will hear tomorrow more about this. To present some confusing work in progress. So this first layer, this conceptual layer I'm working on, where I look at the elements which are needed to analyze intersections between society and the environment. So far it's only a mind map, but I try to sort things and try to see, okay, what do we know, what do we don't know? The same is true for the second layer, the operational layer, so which variables are important, which factors do we have to look at? And so far it's only a mind map, but I think it helps me to sort. Yeah, the third layer, it's still empty. It's just an outline map of Austria in case you wonder how Austria looks like. But that's the easiest task. So mapping the data is not the problem. So I think the challenge is to construct the first and the second layer. But hopefully it will be more colorful soon. To summarize, what do? I develop a multi-layered map in order to describe, to conceptualize and to contextualize spaces of environmental inequality, also to spatially identify vulnerable neighborhoods, and to translate and communicate scientific data into informed policy and planning. My contribution, it's an alternative approach to analyze environmental inequality intersections beyond this classical environmental justice approach. It's also a meta-analysis of multidisciplinary literature to structure the knowledge about environmental inequality, and it should also provide a theoretical foundation to maybe be implemented into a practical application as Chives is. Thank you very much for your attention.
Hard to say all that in English. Would have been easier if you were.
I don't think so, because German is so complicated and longer. The sentences are so long, so I think it was easier. Yeah.
You were inspired by work in Chicago, applying this in Austria. How's environmental justice different or similar between the two?
We observe different sorts of inequalities, so it's not so much a matter of race. It's more wealth inequalities, for example. So the socioeconomic factors are different ones you look at. And in general, it's not so segregated.
Also, you're missing the Euro Cup for this.
Yeah.
Okay.
Sorry.
I said you're missing the Euro Cup for this, having mentioned.
The what?
Oh, the Euro Cup soccer right now.
I said, yeah, I mean, yeah, I don't know, it's so sad.
Good for you.
Yeah. Kind of adding into his comment, environmental justice is getting thrown out a lot, especially in research. Especially that you're saying how you got influence in Chicago, but then it's also going to Austria. Do you plan to define environmental justice differently, specifically for each region, especially if you're saying that in Austria it's mostly more about class than race? So I'm kind of curious, how are you going to approach that with your research?
Yeah, I think that's a good question. I need to think about it, but of course I have to define, like I have to make, for a different definition. And it's more about, as you said, more about class. How I approach this, I don't know.
That's a good answer.
Yeah. Thank you for, and for an interesting comment.
Less central for mapping, but there's this really cool organization called Frameworks that has done a lot of work on how should we frame social issues for like policy audiences or lay audiences or voters.
Okay.
Because people really have heard like environmental inequities, but then using the right kind of terminology and language to get them to the seat and to care about the issue is like, there's all sorts of different techniques. So they do all sorts of like experiments, like what helps people kind of who don't believe in economic injustices, right, and believe that everything's fair, to sort of buy into to framing, and so that might be something to look
Very interesting, thank you. Could you
say the framework?
The frameworks.
Yeah, Frameworks or Framing Institute.
I'll talk to you later. Thank you very much.
Frameworks Institute.
Perfect. Thank you so much. Yeah. I don't know. One more. Yeah.
So fascinating, and as a epidemiologist and health work with but the other thing is what you just said, but you can also just ask them. You just ask them.
Yeah.
What they need. It's very simple. But also,
Depending on my resource, I think that's beyond the scope of my PhD, but as exactly Evo pointed out, this collection of qualitative data is very important for it.
well, like when you have a meeting, in Pilsen or whatever, you just ask them. It's simple. But I really like that innovative approach, and I really like, all the different frameworks. I met this person in London when I was at the World Happiness Summit, and she's a social worker in the city of Ghent in Belgium, and I just happened to meet her because talked to her. And she is a social worker working on environment and sustainability, building like those, when you have to put like a garden or like places that people can meet, and and then you're finding ways to build community, and then people are bringing solutions to their own neighborhood. So it's really cool.
Thank you. Thank you for all the comments and your patience, and I hope you enjoy the reception. No.
Alrighty, thank you for Cha speakers. All right, so that will conclude our presentations for day one. Our reception will officially begin at 5:30. So right now we're going to take a little bit of a break. You need to use the restroom, go use the restroom. Just ask everyone be a little patient until 5:30. I know you guys are probably thirsty for package, so we'll have plenty of drink and food available for everyone to have. So yeah, go take a bath. It's been a long day. Go use the restroom, stretch your legs, do what you need to do, and we'll be back at 5:30.
Oh, that's separate. My colleague, she's like, go to the library and we're like, terms of like what we're talking about, like how do we frame health policy here? Yeah.
It is. It's good. I feel like I'm still rolling pretty well.
Yeah. What was the reason that happened?
Alex. Oh, this is yeah, that's true. Good job,
We can go into the data. The data.
It's just adding straight, right?
Thank you, streamers. Bye.